Hello, good afternoon. If you could come take your seats, we're going to start with the next session. Wonderful. I am Brittany Fair. I am the Manager of Communications for NAC, and we're so excited to have you here today. And we're very excited to kick off our Director Session Part 1. We have presentations from NIA, NAC, NCRAD, and NIGADS. Later we will welcome 4 esteemed speakers for our scientific session focused on TDP 43 and the generalizability of ADRD research. If you're online, you can submit your questions via the Q&A box. If you're in person, please come to one of the mics to voice your question. Once Q&A time is up, we will continue moving along and encourage you to connect with the speakers after the session. All right, and with that, I would like to welcome to the stage Dr. Sanjay Asthana. Please come on up. Dr. Asthana is a professor of medicine at the University of Wisconsin-Madison, director of the Wisconsin ADRC, and chair of the ADRC Executive Committee. Thank you so much.
Thank you, Brittany. Good afternoon. Great to see you all. I'm glad you could join this session, and I also want to thank those who are calling in virtually. So what I thought today, that at this session, I would like to celebrate with you all the many accomplishments and advances that have occurred in the field of ADRD research. In the past few years alone, we have seen some breakthrough findings published in the areas of AD therapeutics, in imaging and fluid biomarkers of Alzheimer's disease and related dementias, in health equity and disparities research, and also a clear and better understanding and appreciation of the impact that things like sociocultural factors, environment, and social determinants of health have on the pathobiology of these dementia disorders and risk and resilience to these diseases. So these advances really have brought us at a very different point in the history of ADRD research. So let me start my first slide. These are just my disclosures, and I have no conflicts for this presentation. So the recent approval of the anti-amyloid antibodies, monoclonal antibodies, I think you all agree, was a monumental accomplishment for the field of ADRD research. And these antibodies have opened way for many more discovery of better agents, less toxic mAbs, and more effective medications for managing these diseases. In a paper published by Dr. Cummings, I think you all have seen that paper, this year alone, there are 164 active studies, and they're evaluating over 127 drugs. And many of these drugs are targeting amyloid and tau protein. And in addition, we have 4 active trials that are evaluating these mAbs in cognitively unimpaired people who are at risk for Alzheimer's disease. So clearly that stage of the disease is pivotal, and we can have any intervention for that stage of the disease. That will be a real breakthrough. In the same paper, he categorizes these medications that are being trialed in phase 1, 2, and 3 into 4 groups: the biologics, the small molecules, the cognitive enhancers, and also those medications that work on the neuropsychiatric symptoms of the disease. And in the same paper, he also summarizes the multiple mechanisms that these medications are targeting. It's not just amyloid and tau, but many other mechanisms that we know are active in these diseases. So just imagine approval of medications targeting various mechanisms active in these diseases, eventually leading to what we all believe will be a combination treatment for this disease. There will not be a single magic pill or a treatment for this complicated disease. The recent discovery and validation of numerous, especially blood-based biomarkers and imaging biomarkers, will eventually allow us to detect the disease early and also study the progression of the disease. It will help us differentiate Alzheimer's from non-AD dementias, and to some degree, perhaps it will help us assess the response to these treatments and eventually risk prediction. There's convincing evidence from published autopsy series that in decedents diagnosed with AD dementia, on autopsy have multiple other coexisting pathologies, and these pathologies contribute to the phenotype, to the disease progression, to response to treatment. And the recent funding of Clarity, you heard from Dr. Johnson, you're well aware the mission of Clarity is to focus on the coexisting pathologies and develop harmonized protocols to collect imaging and fluid biomarkers that will help us examine the effect of these comorbid conditions and pathologies on disease progression. Again, another breakthrough in ADRD research. The focus on health disparities and equity research is generating data for us to better understand how the neurobiology, the genetics, and the clinical phenotype of these diseases will differ in different races and ethnicities. And we have discussed multiple times how critical this area of research is for the field. And also, we are able to diversify our cohorts across the ADRC network, and that in turn will enhance the generalizability of research, of our findings, and translatable to many populations across the United States, and certainly the marginalized populations across the United States. One of the areas that I think as a community we have to focus on is the real-world data. And today we'll have a presentation from Dr. Robert Califf, who is the FDA commissioner and an authority in this area of research. And this area of research, in my opinion, needs more growth and more interest in a scientific community. These data, as you know, are derived from something like electronic health record, on claims data, and also on cost utilization data. So based on a brief intro I gave you, the ADRC Executive Committee identified these two overarching themes for this session: TDP-43 as a non-amyloid mechanism, and of course, generalizability of ADRD research. On each theme, we'll have two presentations. In the TDP area, we'll have a presentation on basic biology of TDP-43 by Dr. Margaret Flanagan, and Dr. David Vogt will talk about the clinical definitions and biomarker development for late. Dr. Vogt is the UPenn ADRC director, and Dr. Flanagan is the Neuropath Core director at South Texas ADRC. In the area of generalizability, we'll have two presentations, one by Dr. Rachel Whitmer from UC Davis. She'll focus on selection bias and representation, something which was brought up in the earlier sessions. And also Dr. Califf will focus on real-world data with attention on electronic health record. So with that, I would like to invite the first presentation from Dr. Amy Kelly. Dr. Kelly is the Deputy Director of the National Institute on Aging. She works with the NIH director and provides strategic leadership and oversees all the operations of the Institute. Prior to coming to NIH, Dr. Kelly was Professor and Vice Chair for Health Policy and Faculty Development at the Brookdale Department of Geriatrics at Icahn Medical Center at Mount Sinai. And she also, at that same institution, served as the Senior Associate Dean for Gender Equity. Please join me in inviting Dr. Kelly to make a presentation. Dr. Kelly.
Good afternoon, everyone. It's great to be here with you today. And for those of you online, I'm glad you're with us as well. It's such a big group and such a fantastic morning to get us started. Let's see there. Okay. The first update or announcement I suppose I wanted to share with you today is that 2024 is actually the 50th anniversary of the National Institute on Aging. So we're taking advantage of this year to not only reflect a little bit of all that has happened in aging research and within the Institute and around the world in this area, but also what is ahead of us, and really hoping that this is an exciting time to draw more people into the field and engage with broader groups of people in all of the exciting things that come next. I wanted to start today with just a few updates related to our budget and spending. Some of this is probably familiar information to many of you, but in late March, we received a final budget for FY24. This included $48.6 billion for the NIH overall, with a provision for 4.51 for the National Institute on Aging. We were one of the very rare spots in the budget at NIH to get an increase that included earmarked funds for ADRD research of an increase of $100 million. That was designated as $90 million for NIA and $10 million for our partner institute, NINDS. We also received a targeted appropriation of $12.5 million to support a trans-NIH coordinated effort for palliative care research. This is a graph that I think we show you at each meeting with a little bit of an update. So you can see here the really dramatic growth in appropriations to NIA over the last decade. And the blue part of that bar is the cumulative appropriations for AD and ADRD funds specifically. There is a period of really rapid growth and perhaps the beginning of, a sign of a plateau there in the last year or two. And that is a good segue into our current pay lines. This is updated information just as of about a week or two ago, now that we have the budget and a little more clarity on what the finances look like this year. We've set pay lines for all applications that are reviewed by the Center for Scientific Review. So you can see we've got a lot of different breakouts here. On the left-hand side is the general line, 2 columns split by size of the application. And on the right-hand side, the AD/ADRD specific columns. And again, in this case, this is the first year we've instituted a second pay line for those applications that have direct cost in any given year of $5 million or more. You can also see, as we typically do, the new investigator and the early stage investigator lines, we give those a higher pay line. This speaks to one of our core values of supporting the development of early career investigators in the field. For those applications that are reviewed by our own study sections inside of NIA, you can see the pay lines are set by their overall impact score. And again, we have a general and an AD pay line. You'll notice again that we have the Career Development Awards and the Fellowship Awards with a little bit of a higher bump. I'm going to move on to just a few updates from NIA in terms of research. This is a list of cleared concepts that are approved by our National Advisory Council at our last meeting back in January. Our Advisory Council meets 3 times a year. Often one of the topics is concepts that we propose to the Council for their approval. If you keep an eye out for our blog or other updates, these are things you'll see coming out from those meetings, usually within a week or two. But I wanted to share with you a few that are very specific to AD and ADRD. So I won't read them all to you here, but you can see these 4 listed from January's meeting. And then in addition to these 4 that are related to AD/ADRD, there were a host of concepts approved for our general aging research portfolio. Again, I won't read those concepts to you, but I'd encourage those of you who are interested in areas that we are finding great interest or future priorities to keep an eye out or look for more detail on these topics. I also wanted to share an update, and this really builds beautifully on the last presentation about our portfolio, what we're funding, and the great range of initiatives that are happening, particularly in our clinical trial space. So this graphic gives you a sense of the over 500 clinical trials and the spread by topic areas, so pharmaceutical, non-pharmaceutical, care and caregiving, as well as diagnostic tools, treatment for neuropsychiatric symptoms. And I wanted to give you a little bit of a more detailed breakdown. In particular, if you look at the pharmacological trials, 73 overall, On the top part of that left side in blue, you can see those that are in the earliest stages. So we've got 60 trials that are in phase 1, phase 2. And in that box, you can see the range of disease targets. So really wide breadth of target areas. And then at the bottom, the 13 remaining trials in the pharmacological category, again, targeting a wide range of focus areas for the disease. So 5 certainly focused on amyloid, but a whole host of others. Similarly, in the non-pharmacological trials, again, you see a really wide breadth of modalities that are the focus of those trials. Those tend to be less expensive trials, and there's a greater quantity of them overall, but they make up a really important part of our AD/ADRD clinical trial portfolio. Similarly, the care and caregiving trials, not only do you see a wide array of types of trials, but just to highlight for you, these focus on care in a variety of care settings. So in the community and long-term care, many of these trials focus on care partners or caregivers, decision-making, advanced care planning, again, a whole range of focus areas for those trials. And then finally, a little bit of a smattering in the diagnostic tools, imaging studies, as well as treatments for neuropsychiatric symptoms. One piece that I wanted to share with you, which might not be as familiar to this audience, is our small business program. There's a lot of translational work and important interactions that happen across the small business space and the research space, and every year this is a specified proportion of our budget. So we award on the order of $150 million annually for our small business innovation research program, as well as our small business technology transfer program. This is also an area where we have a lot of interest in bringing additional people into the field, people who might be in the research space and are excited to build an entrepreneurial aspect to their career, or take an innovation and develop it as a small business. And so one of the initiatives we've had over the last few years is what we call our Startup Challenge. This is a competitive program where applicants are selected to participate in intensive training. They have mentorship. They work with a cohort of peers. And at the end of the program, they give a pitch for their particular innovation, their small business, and 6 finalists are given a cash prize, which is intended to be startup seed funding for their small business, and also hopefully a good leg up for a competitive SBIR application. So if that sounds like it's something of interest to you or any of your colleagues, please do watch out for the next announcement of that program. I am really glad to see how much effort and focus is part of the discussion at this meeting around health equity and how that is translated to so much of our work. I wanted to share with you a bit of NIA's effort in this space. Our commitment to diversity, equity, inclusion, and accessibility is something we hold dear and are really working on integrating into every aspect of what we do at NIA. And in particular, it's important that we are supporting, conducting, encouraging research that is going to benefit the health and well-being of all people. Historically, we haven't done that well, I think, as a broad research enterprise, and it's something we really want to improve upon. And so as I have heard mentioned here today, this is not simply about demographics or checking a box. It's about representing the people who are impacted by a particular condition, a particular illness, so that our studies are truly generalizable to the folks who are out there living with those conditions. Now, one of the ways we have to institute policy in support of this value is in our awaiting receipt of application policy. So when an application is coming in and it's going to have direct costs of over $500,000 per year, there has to be an initial step to have approval to submit that high-cost application. That gives us an opportunity to engage with the investigator and to understand better their intentions around inclusion and enrollment for that study, and to really scrutinize and work with them to ensure that it is going to yield evidence that is helpful to the full real-world population of people who have that condition. So as it's been mentioned before, this is not necessarily only characteristics that will be captured on the standard inclusion and enrollment table. So many of you who've put together applications know that that's race, ethnicity, sex. It doesn't capture some of the other populations that we know are underrepresented, that we know are affected by conditions, and that we want to see in our research studies we fund. So those are socioeconomically disadvantaged, rural populations, section gender minority populations. So please do look at our website for populations that we are interested in, that are underrepresented in research. Think about the true population that is affected by the condition you're studying. And if you're involved in putting one of these applications in, please help us to understand how it is your study is going to better inform the evidence needed to support the health and well-being of that group. And then how are we going to hold ourselves accountable for knowing we're achieving these goals? So as many of you know, a couple of years back, we launched the Clinical Research Operations and Management System, CROMS. And I'm glad this is not the lunch session, because there might be a tomato tossed at me. I know that it's been a learning curve, but we really are excited about CROMS. This is a way to track the enrollment in a more real-time manner. So it's about monthly that we get input from investigators. There's a learning curve, there's bumps in the system, but we're really excited about what the CROMS system can show us. So the idea here is that on that top bar, you'll see kind of the monthly notes along the bottom. The blue line was the proposal in the application about the rate at which the study would accrue. You can see the orange line is what's actually happening. And in this case, this example study, you can see, gosh, they're off to a real slow start. And by getting that signal early on, it allows the investigator and the program officer to check in and say, hey, what's going on? Is there a way we can help you? Is there some way to correct course, so that we can get those studies back onto the curve that they intended, so that they achieve adequate power, that they create the evidence they were hoping to generate, and that the value of that study is as high as it was intended to be. You can see in the charts below, we also, through the CROMS system, have breakouts that are by race, ethnicity, and sex. Over time, we're hoping that that might even be more granular, get at some of these other populations we're hoping will be represented better in our clinical studies. But we really see this as a tool for engagement, for early recognition, for how we can help studies that we're supporting achieve all that they had set out to accomplish. And we realize that's really hard. It's achieving enrollment, as I've heard today from so many of you, with a lot of concerted effort, is still really challenging, and we're all learning better ways to do it as we go. And so we also want to be a part of helping create those solutions. I wanted to highlight here just a couple of things that we're doing at NIA to support better practices for inclusion and enrollment. On the bottom, you can see the Outreach Pro tool, which is specific for recruitment materials that are culturally vetted and in an array of languages. I believe there's maybe 7 or 8 different languages available. And that middle one, ADOR, is a repository where studies that have successfully created materials and are willing to share them are available for other investigators. And so creating a hub where we can really help raise the tide for all studies that we're supporting. So please do check those out. And then lastly, I also wanted to mention that we're really thinking about, what are we doing within our own house at NIA. So last year, the NIH overall created a diversity, equity, inclusion, and accessibility strategic plan. And right now at NIA, we are in the midst of doing our own process, really thinking critically about 4 areas of DEIA that we want to focus on improving our practices and setting strategic goals. So these include internally focused areas like our workplace climate and our internal workforce, but also those that are externally facing, including how do we ensure we're bringing the broadest array of perspectives to the workforce that we're supporting in the scientific pipeline, focused on aging research and Alzheimer's disease and other dementias, and how are we conducting our research? So whether it's about appropriately representative enrollment in clinical trials or studies that are specifically targeting understanding and ameliorating health disparities. So a couple upcoming events to share with you. I am hoping you will all save the date for our next Research Summit, Alzheimer's Disease Research Summit this September. It'll be the 23rd through 24th, so you can mark that off on your calendar, really starting to think about that path to precision medicine. So that should be a great set of content like all of the summits are. I already mentioned our anniversary. This is a QR code you can scan to see some of the things we have already posted or watch for the rest of the year on X or LinkedIn. Contribute your own stories. Again, this is really not only celebrating the anniversary, but a chance to look forward and to help those who are coming into the field, ideally, build excitement for all of what is ahead. And as I've mentioned a couple times throughout, we have a whole range of blogs, listservs, again, LinkedIn, X, other ways to follow what's going on at NIA. But we really do want you all to stay in touch, and we'd love to hear from you as well. And with that, I am going to say thank you and hand it over to my colleague, Dr. Larkin.
Hi there. It is wonderful to be here. I love coming to the ADRC meetings. I learn so much every time. I'm Jenny Larkin, and I'm the Deputy Director of the Division of Neuroscience, and I'm trying to figure out how to make them go forward. There we go. I did it. All right. So first, I'm going to do an introduction to the Division of Neuroscience, and then I'll walk through some other things. And at first, I thought, why should I do this? You're all supported by DN. You know who we are. And then I realized there may be people here who are relatively new, either in person or online in their career or to NIA, supported research. So this is also for you. So the Division of Neuroscience is one of 4 extramural scientific divisions. Our mission is to foster extramural research, and especially very collaborative research and training to further our understanding of the brain and behavioral processes in the aging brain. And of course, one of our major focus areas is on dementias of older age, especially Alzheimer's disease. And our core aim is to promote understanding of the aging nervous system with the goal of really fostering the highest quality life for the longest possible time. The graphic here shows that our research area encompasses really understanding aging. We have a major focus on the interplay between genetics and aging, and also bringing the environment in, because between these 3 factors, aging, genetics, and the environment, they interact to produce the physiological effects of health or disease, resilience or pathology. So we have major research programs on understanding degeneration and understanding proteinopathies. Of course, I'm just the deputy. Also here today is Eliezer Maslia, who is the division director. All right, so I stole part of Amy's slide. So yes, this is the 50th year of National Institute of Aging. That is super duper exciting, but that's not the only amazing anniversary, because this is also the ADRC's 40th year. ADRC's been going since 1984. And the slide says this, but it's really true. The ADRC program is a national resource for research into Alzheimer's disease and related dementias. You have an amazing breadth of knowledge, of expertise. You drive forward new protocols, and you're a wonderful resource for the community. So yay you. But that's not all. This is also NAC's 25th year. Let's hear it for NAC. NAC hosts the largest relational database for AD-ADRD research for standardized clinical and neuropathological research data. So 2024 is a banner year. All right, so you cannot be from the federal government and not actually show an org chart. Don't worry, don't worry. But I had to do it anyway, just to point out that not only has the research field grown exponentially, perhaps, with our massive increase in budget, but we within DN, we've grown a lot as well. We were, Eliezer Meslier reorganized the division a number of years ago, so we now have 5 different branches, but as we're moving forward, we're continuing to grow. But there are 2 areas where we're especially organizing and staffing up and making sure we have the resources internally to support you. One is in data management and sharing. You can't even see it, but there are little blue asterisks that are appearing. All you need to know is there are little blue asterisks throughout the org chart. So we have people throughout our organization that have expertise in data management and sharing. You can reach out to your program officer, to your favorite health specialist, and they're there to help you understand this policy and make sure that you can implement it in the best possible way. Internally, within the Division of Neuroscience, they all work together to make sure we are as consistent and informed as possible. The other super important area is clinical trials oversight. Amy Kelly told you a lot about our new systems and our new focus, and of course, we're staffing up even more within the Division of Neuroscience to make sure that we have the internal expertise to be able to support you as well as the Institute's needs in this area. All right, so that was enough for the org chart. So I want to go through some science highlights, and I thought about this for a while, and we decided to highlight an area where maybe you know, but maybe you would actually learn about some new opportunities as well. Or maybe not, but I tried. All right, so the science highlight is really looking at and highlighting some of the activities that NIA, and especially Division of Neuroscience, support in cell atlases and connectivity atlases for aging as well as Alzheimer's disease. And what you see here is a listing of 4 different RFA programs that are supporting comprehensive multimodal atlases as well as brain-wide connectomes. And the goal here is to have a cell-level understanding of disease, pathology, and connectivity, and how they're changed in aging as well as in pathologies. And I'm not going to run through all of these, but I think the slides are available. But what I want you to see here is it's a very thoughtfully developed program that over the past 5 years or so has been releasing every year to a new RFA program to explore different areas to build this up. What this has resulted in is a sort of comprehensive program supporting multimodal atlasing across both human and mouse model systems. So if you look on the left side of the slide, you can see the various awards that are developing and fleshing out connectomes, both in humans, that would be the U19 Aging Adult Brain Connectome Atlas, as well as in an important model system, the mouse. So you can see there are 4 different UO1 awards exploring and developing connectomes in the mouse. On the right side of the slide, you can see atlases, so cell-level atlases of the brain, both again in the human, that's the U19 Seattle Alzheimer's Disease Brain Cell Atlas, the CAD, as well as 5 awards doing similar sorts of work in the mouse. But as always, resources are only as good in some senses as the projects that use those resources. So what we can also show off here on the bottom is secondary analyses. This is just an example of 5 current awards that are leveraging these resources that are being built to drive forward our knowledge and understanding in the area. Did want to give a little shout out to the Seattle Alzheimer's Disease Brain Cell Atlas, CAD, because it is a collaboration between the Allen Institute and the University of Washington Alzheimer's Disease Research Center, as well as Kaiser Permanente Washington Health Research Institute, and they are developing a multimodal atlas. And a resource that is available to the community. And they can tell you more about this atlas than I can. All right, so the one other thing I wanted to mention, so all those atlasing projects were coming out of part of one of the branches in our division, the neurobiology of aging and neurodegeneration. In one of our other branches, the population studies and genomics, they're also developing a suite of programs to help us really understand precision genomic medicine, often all the way down to a single cell level. And this is a suite of a number of different RFA programs, again, all driving to flesh out a more comprehensive understanding of the Alzheimer's disease genome, with different RFAs focusing on understanding RNA modifications, really understanding different gene and variants, non-coding RNAs, including long non-coding circular RNAs and others, as well as transposable elements. They're also integrating environmental factors to try to understand what is the interaction between environmental factors, how are those coded into the Alzheimer's disease genome. And the whole result of this is to help us really understand and identify causal mechanism to help drive target discovery for Alzheimer's disease diagnostics and therapeutics. Really, the image here is then to be able to, with those possible targets and possible therapeutics, hand it over to one of our other branches, the translational research branch, to have them investigate it more fully, and then it comes full circles again back to our clinical interventions and diagnostics, where we support the trials and other clinical research. So that was a science highlight. I'll just do a few more of the funding opportunities that we thought might be of particular interest to the folks at this meeting. So the first one is active new funding opportunities that are open right now, right? That's the money pitch. Okay, so at the top half are the research funding opportunities, and on the bottom is for the career development and fellowship opportunities. I've also, on this slide, I have listed the actual receipt dates because I know those are important. So I'm gonna take just an extra minute or two and walk through these. So due this July 2nd is applications for the Palliative Care Research AG 25002, and due June 13th and the 15th, there is AG 25005, the Open Measurement Coordinating Network for Non-Farm AD/ADRD Prevention Trials, and the Multi-Scale Models Bridging Levels of Analysis in Aging and AD/ADRD. Also due in June on the 10th is exploring proteogenomic approaches to unravel the mechanisms of misfolded proteins in accumulation and tauopathy. That's right in line with one of the themes of this meeting. As well, due this fall in October are pilot studies for the spectrum of Alzheimer's disease. At the bottom, we list a number of different training and career development opportunities due on June 14th, our research training in aging for medical students. Due in just a few weeks, on May 24th, is both post-baccalaureate research education program and the summer research education program. So if you're early in your career, please take a look at those. There are also some recently approved concepts that Amy already identified a number of them, and again in this slide they're split out in the top half. It's by the research areas, so access and manipulation of brain subtypes, the Alzheimer's disease drug development program, biomarkers of cognitive decline, focusing on people with autism spectrum disorder, deciphering the impact of RNA modifications in AD/ADRD, and investigating mitochondrial nuclear communication in AD/ADRD, as well as a number of career development opportunities, including our GEMSTAR program and summer research training programs for medical students and for translational research. The last thing I want to say is NIA has a number of different AD/ADRD training and career development programs. I'm not going to walk through them all. We also have parent K08, K23, and K24 programs for medical students and those people interested in moving into research. But you don't have to worry if you didn't get everything, especially in the training and career development on these slides, because we have a fantastic training office. And the people in that office are Maria Carranza, Jamie Lovick, and Laura Major. You can just reach out to them super easily at niatraining@mail.nih.gov. They're wonderful, they're highly responsive. You can ask them any questions. You could even send them specific aims. There's a super useful website as well, and we have a newsletter. So if you're early in your career, I very much would encourage you in looking into these resources and reaching out to them. And with that, I think that's it. Thank you. And next up, I believe we have Cerise Elliott. Is it correct? Did I get that right?
Okay, good afternoon. Thank you for coming to the meeting. I'm so excited to see everyone. And if I haven't, pulled you aside and told you personally that I'm excited, I got another day and a half, so I'll see you. Happy anniversary, everyone. So in the 40 years that we have been ADRCs, we've had 107 directors, we've gone across 27 states, and with the combination of MDS and UDS, we've had over like 125,000 participants and 18,000 NeuroPath sets. We have like 1,300 publications using NAC data. We have almost 200,000 clinical assessments, and I feel if you haven't learned over the few years that you and I have been together, that we're really into the network of the centers, and we think that the whole of the center is better than the individual pieces, and we are always looking to move in that direction. That's really bright. Okay. Why are we here? Because we're all excited. It's not just for the tacos or the barbecue or Terry Black's, because everyone has told me they're going to Terry Black's. So I'm just like, okay. We're here because, we're trying to collaborate in large groups and further the ADRC program. And so first of all, I just want to thank everyone for being here. So thank you to all the steering committees, all the surveys. Know that surveys are going to be more because we're going to be more collaborative. So thank you for responding when we reach out. Thank you to all the presenters, all the staff members at NIH who I only see at the meetings. I really appreciate seeing you here. And NAC, everyone who's here, everyone's online. Like, there's so many people here, and it takes a village. So thank you. Again, we're trying to orient everyone into the steering committees. I think we've had really lively elections the last couple of cycles. And we're really centering this method of working in the steering committees to set goals and accomplish things for the year. And I think you saw this morning in the biomarker session and the imaging session, and even in the clarity session, where we're working with the steering committees at the point of contact to try to work among the 30 or so of you. So if you're interested in taking a more active role, if you really want to be on board, or you want to take us in a different direction, consider participating in the steering committees. Look for nomination emails from NAC. The list of the current members are available on the NAC directory. And also, some steering committees, knowing that we're relying them on more to, set goals and have accomplishments, they're really open to incorporating perhaps more early and stage investigators. So it's not just like a senior year project. We can have some freshmen come in, and so that's some steering committees are open to this idea and have been working towards that. These are the list of the steering committees here, and we have fall committees and we have spring committees, and so we're in the nice blue. So I'm just going to highlight some of the ones I think you should pay attention to. The Biomarker Core Steering Committee, and I wasn't going to do it, but I shouted out the REC again, because the REC is just doing a lot for all of the early stage investigators. So the Biomarker Core. I've been really working hard on this Biomarker Core. I decided to put this nice little timeline here that, I even go past 2018 because I felt like 2018 was long enough for you to get my point. But in the RFA, during that year, we've established biomarker cores in the P30, and we established a steering committee 4 years later in April of 22. And so since April 22, we've kind of surveyed you about 2 or 3 times about fluid biomarkers, and we're trying to come together to have some consensus about how to centralize this data. That's always going to change. I'm not going to deny that. And so last May, we kind of had a survey discussion and a call for volunteers. And I just want to say thank you to all the biomarker core leaders who rose their hand and waited patiently for about 4 or 5, 6 months for us to come to work in January. And so the groups kicked off in February. We had a follow-up survey real quick. You guys answered. And then this morning, you are all here to hear what the results were, what the working group discussions, and what they've been kind of discussing in the last 3 or 4 months. And so this work is ongoing. This work is fluid. This work will always change, and I think there will always be challenges. And I think that the role of volunteers is always open and available. So that's my spotlight. My other spotlight is tomorrow. And I'm really excited about it. I'm so excited about it that Sarah's going to mail this placard that's out there to me to the office. So, UDS4 implementation. Here's our timeline. We have lots of targets to make. So we're going to have the implementation part. We're going to have some pilots. NAC is really deep and the team is deep into making sure that you have resources available so that you can transition. There's training and support. And we're also working on Spanish and Chinese translations of the UDS version 4. So I'm kind of spoiling Sarah's presentation, but it's cool. Let's see. August, we're going to try to, start, work on completing the packets and saying that they're done. And we're going to start pilots. We're going to debut, letting you know that pilots are starting. And we hope that by the end of the summer, we'll have all of the resources developed and, have that deadline of when we stop using the version 3. And I just want to shout out to the clinical task force. It's been a labor of labor. I won't say love. I think for the last 5.5 years, we've met every other week. Also, if you volunteer for a steering committee, you can talk to Nina and I every other week. So I think that's a perk. So you can always go online for the forms and updates. They're available. There's a table that's totally the implementation table, and it has all the forms and packets available for you to take back. and have hard copies, so there's a table for that. So tomorrow, come back here at 10 o'clock, and you'll learn all about the implementation plans that NAC has in store for you. Write in your calendars, everyone online right now, about May 14th from 8 a.m. to 1 p.m. Pacific time, the 4.0 virtual training. Okay. My other highlight is the rec session. We have 35 early stage career investigators here live in person. They're going to be part of the poster session that starts in the morning at 8:30. They loved the mock study section so much. Last spring, they decided to do it again. So there's about actually probably 65 people going to participate in the mock study section on Wednesday. There's a rec-specific newsletter to rec leaders. There's a scholar diversity work group. There's a mentoring program, which they started. And I think like this year would be like the third year they've done a networking social at AIC. Clarity participants do not satisfy the P30 imaging requirement. That's my headline for today. You learned this morning the goals of Clarity. I won't repeat them. I just wanted to make sure that everyone is aware of that Clarity happens, but also as you compete for P30, there is a P30 imaging requirement that is separate. This is Mayo Clinic slide. I'm going to speak for Cliff right now, and Bill presented it this morning at the Imaging Corps Committee. If you have questions about the MR protocol, I think that it would help us all if you outreach to Mayo at scanmrimayo.edu and have Brett work with you. I think, if everyone kind of can go to the protocol and, highlight what's not clear about the protocol so that we don't upload exams that are prior to January 21, that we don't self-deface, that we don't self-anonymize, and that we don't upload the same exams multiple times and don't have wrong patient IDs. And I feel that that will help the Mayo pipeline a lot, and it will help us, work forward. So if we could get feedback on that, that would be great. We would more than willingly update that protocol. Another table that's outside looking for eyes is ALZPED. It's the Alzheimer's Disease Preclinical Efficacy Database. It's something that we at NIA have been building since the 2015 summit. It hosts summaries of published studies, and it's a platform to have citable reports and preprints to include studies with negative findings. It's developed to, have reproducible preclinical efficacy testing in the animal models. And Dr. Vishwanathan, I see you. Are you here? Stand up. Jaya is here. She is at the table. Go visit her and learn about ALZPED and how you can incorporate the resource that NIA has built. Additionally, the CARE 2.0 team is out on the table. If you could stand, Kenny is, and who else was in the table? Yeah, he's in the back waving. He's at the table, and he is representing CARE 2.0. CARE 2.0 is one of my R24 recipients that have recruited more than 10,000 Asian Americans, Native Hawaiian, and Pacific Islanders into their registry, and they have various languages available: English, Chinese, Hindi, Korean, Samoan, Vietnamese, and they're looking to help you increase your representation, and you could go and hang out with them. We're going to, and also, there were other tables out there, and I wrote it, here we are. There's the Okay, I told you about the timeline table. That was great for the UDS. There is the ADRC portal table that you can learn about your portals. The digital voice people came back this year, and they're out there. Oh, and Clarity, I didn't even know had a table. Clarity has a table. Everybody's out there, they want your attention, and they want to teach you and share their knowledge. So please, as you gossip out in the hall, come out to the tables too. The second thing is we like to bring to your attention to help you attribute more credit to the ADRCs to ensure that when your resources are utilized, that the ADRC is accurately and adequately acknowledged, and also acknowledge all the infrastructures that people receive data from, NAC, NCRADScan, NIGADS. I feel sometimes people miraculously think they get data from somewhere, and they don't really communicate fully where that data came from. And I think it's important if you could increase that attribution. Just a reminder, I don't really have to remind you because everybody's told me. You know that second receipt date is June 14th. If you could, in your letter of intent, include your optional cores if you're including them. And the third receipt date is next September. Also, with your new applications, there's new policies for the data management and sharing, and there are requirements that are listed here for the final NIH policy on data management and sharing. The NAC team and the data core, and I think it was also the EDC work group have worked on specific plan resources for you available at the NAC website. What we expect is a plan for you to plan and budget, submit a plan, and the plan should address 6 recommended elements that are outlined in this notice from the OD, and you have to comply with this plan that you submit. And you should expect a request from us to revise, because we're all in it for the first time and we're all learning together. Peer review will not see your DMS plan, and it's a program responsibility, and we're all really excited for it. Our next thing is about measuring progress. I feel like I made this a theme like the 3rd time, so I just want to remind you that we're trying to measure progress. People are more interested in about what you're doing, and so we're really, trying to work out ways where we can get information that isn't a survey and get information that isn't a progress report. So, administrative, Grayson changed my slides because I had life-changing administrative projects on here, so I'm just going to vocalize it. I did Audible. And so we're going to try to do administrative table red cap automation. Ann Arthur from Kansas introduced the idea last May when we were in DC. So the administrative steering committee and NAC is kind of working on that. Also, in light of the congressional questions about populations and recruitment and the actual participant demographics, we're looking to work with the administrative and the core collaboration to figure out how to understand the recruitment and staffing activities for all the affiliated studies across the network and come to some reporting structure that we could work out with NAC to make it more collective reporting about how you're reaching out to your communities as a national program. So just know that the rest of the year will probably be focused on some surveying, trying to get some information from you. Okay, so the incentive for Fluid Biomarker Initiative has been completed. So together, we've provided over 21,000 blood samples from over 8,000 visits and 6,700 participants. And in April of 2022, we provided about $400,000 to distribute to the centers to initiate the submission of biospecimens to NCRAD. And that was, a cash incentive to make it happen. And that gave us time to provide additional $925,000 in direct costs to P30s following their competition. And that, that started in the release of the announcement in January 2023. And so, with this increase in funds, we also changed your terms and awards conditions of your P30. So as you follow competition, there's a condition that your biological specimens collected by the center must be made available to qualified researchers, either locally or through NCRAD. And there's another sentence in there that says, if it's locally, you gotta tell us how do people get it. So in April, I sat down and calculated things, and the average reimbursement to center was about $12,000 to incentivize you to do the initiative, and it equals about less than 1% of the average unobligated balance of your awards. So I just want to say I think you have some funds in order to complete the initiative or the sharing of your specimens to NCRAD. And of course, it tells me again to let you know, don't carry unobligated balances. Do your best to go to zero, please. Because the grants policy statement states there's a principle of first in and first out. And as a highlight, the offset of a current award or a subsequent award by amount represented of some or all of the access. So if you have really high unobligated balances, program can and grants management can offset the current award or the next year award by how much you have unobligated. And it becomes more and more important as the budget climate changes. So I feel like this is the third time I've presented this slide, and so I really mean it. So now I'm really excited because we brought you a new member of NIA to come and join the party. And we're going to bring Dr. Brian Gray. He's going to tell you about the Office of Legislation, Policy, and International Activities. And he, you want me to do the summary or no? You got it? Okay. So Brian, I'm really excited for him to join. So thanks.
Well, thank you, everyone. I appreciate you all having me here today, and thank you, Cerise, for the really kind intro. And I will do my very best to keep the energy up from where she had it. That was great. I think we all need that kind of talk, right, each day. But I'm really excited to be here with you today to talk a little more about an office that operates a little more behind the scenes at NIA. So we'll get right into that. The Office of Legislation, Policy, and International Activities. All right, and these are our key activities. I'm not going to read all of this to you, but there's kind of three key and overlapping buckets that we operate in. So first is we manage the international activities for the agency. We carry out our engagement with our strategic partners, and we play a big role in our managing our legislative and policy activities. So I wanted to talk a little more about that, but first, this is our condensed org chart. So we're a small office, just 8 people strong. But our director and deputy director are there on the left, Courtney Wallen and Jill Beaver, and then a very small team of very highly dedicated and highly efficient folks that cover all the rest of the bases. So a lean team, and I don't want to say mean because I feel like they're the nicest people you'll meet, other than yourselves, of course, but a really great team to work with. So let's get into the first set of activities. So international activities. This is led by our deputy director, Jill Beaver. And I think the key message here is people from around the world want to know about all the exciting stuff happening at NIA. They also want to share in those, share in that mission of advancing research in Alzheimer's disease and aging research. So there's a lot of really cool new opportunities coming to grow the research endeavor in meaningful ways, but also to share the various resources that we have at NIA with the broader community. So there's a number of different activities that take place, lots of in-person visits that are starting to come back online now that we have COVID a little more managed. Virtual meetings are still a big part of our day, but you can see a recent visit here. I think this is a delegation from Hungary that came recently, but we have quite a few visitors to our various facilities. Moving over to some engagement strategic partners, a number of different activities managed or led by Elizabeth Prickett in our office, but really focused on developing and managing key relationships with strategic external partners, and then also managing a steady flow of information into and out of the agency. So you can see some of the activities here. Lots of meetings and workshops, including our big Friends of NIA meeting every fall. Tons of news updates that get sent out every 2 weeks or so. We have office hours with the OLPIA team, and those office hours have included a few different kind of configurations, but lately has been having some of our program officers and some of our awardees present their research activities, and then we have kind of an open Q&A after that, and then responses to requests for information and that sort of thing. All right. We curate a tremendous amount of scientific information. Thanks to all the work that you do, NIA produces a lot of scientific information. There's a lot of scientific output. So it's tremendous. And so we help try to make sure that's put out to the broader community in a reasonable and accessible form to our congressional stakeholders, to our public stakeholders, to advocacy communities and that sort of thing. I put 2 examples of some of our big products here. On the left, you'll see the Alzheimer's and related dementias professional judgment budget, which outlines the resources needed to make significant advances in the field. We project this 2 years out. So we released the fiscal year 25 version last July. This July, we'll be releasing our fiscal year 26 version. And then on the right, you'll see our Dementia Research Scientific Progress Report, which highlights all of the key advances in Alzheimer's and related dementias research from the past year that NIA funded. So it's obviously a high-level overview of that because there's more advances than we can possibly talk about, but we try to put out a compelling document each year. All right. And then getting into engagement in Congress. So these photos are pre-COVID. We haven't had a ton of in-person meetings with our appropriators and our senators, but so you'll see Francis Collins in there, who's no longer running NIH, and we have Dr. Bertagnoli instead. But tons of different ways to engage with Congress. You'll see on the left a briefing with Senate appropriators. You may see your senator in there. We have a couple retired folks in there, but Senator Collins is in there from Maine, a few others that you may recognize. And on the right, tons of meetings that Dr. Hodis, Dr. Kelly, and our NIA leadership take with our elected representatives to provide them information on the current research endeavor. They are very, very interested in Alzheimer's and related dementias, as well as the broader aging research portfolio. So we field a number of requests every month from these individuals on their interests and what sorts of research activities are there for them to learn about. So just to give you a little highlight, just on briefings alone, leadership and subject matter experts have participated in 25 briefings in the past 16 months. And these are some of the major topics you'll see on the right. Obviously, Alzheimer's and related dementias is our biggest one. But menopause, we've had several briefings on that recently. Healthy aging, sleep research, social isolation, and falls prevention have been really big topics. And for each of these briefings, we often usually have quite a bit of written follow-up and engagement with those members afterwards as well. So it's the start of a conversation, and it tends to be an extended conversation with them. But they're very interested in learning about the current state of research in these areas and where the needs are, how they can help. So they're really great conversations, and we appreciate all the work that you're doing to move these fields along because it gives us lots of really cool stuff to talk about. In addition to engaging with Congress, we also respond to requests for information. We get a lot of written requests for information from the members themselves. Sometimes they just want a quick update on prize competitions and that sort of thing. But we also get more formal requests. This often comes in the form of instructions that are embedded within each year's appropriations. And so I think I wanted to highlight this example from last year's appropriations bill. This was specifically focused on ADRCs. We got a request or instructions to provide a report to the appropriations committees detailing all of these key components about ADRCs, how many patients have gained access to a clinical trial through ADRC outreach, how many diagnoses have been received, and that sort of thing. And so I know this, as Cerise said, was a labor of labor. I know this went out to all of you for information. So I wanted to say first, thank you very much for providing that information. That was really critical to making this report happen. So give yourselves a round of applause. Thank you, thank you, thank you. I also wanted to, yes. I also wanted to say thank you so much to Nina and Cerise and Grayson for helping facilitate that. That was really critical. And I guess this is also my chance to say thank you in advance for any future requests that may come down from Congress. As I mentioned, they're very interested, they're very engaged, but with that comes increased requests for information and reports like this. So thank you again in advance for the stuff to come as we see. All right, I know you've seen this slide many times today, but if any of this was interesting to you today, I definitely encourage you to stay in touch with us via the modality of your choice. We have many options for you to pursue there. And with that, I think I'll say thank you one more time, and I think we're moving to Q&A at this point.
We'll welcome up to the stage now for Q&A Dr. Larkin, Dr. Elliott, and Dr. Kelly. Of course, Dr. Gray can stay.
Questions or comments, anyone?
Hi, Suzanne.
Thank you. Suzanne Kraft, Wake Forest, ADRC. I have a question for Dr. Kelly. So I've been getting panicky messages from my junior faculty over the apparent change in pay lines. And so I'm wondering if you can help me explain to them, because it doesn't seem like less money is coming in, or, that I would just like to understand that a little better in a way that I can convey it to them and not have them running to the cancer field.
Well, we certainly can't have that. Okay. Well, so I will do my best to explain. I think it's definitely something top of mind for everyone. So we, as the AD/ADRD field, have benefited tremendously over a decade now of targeted appropriations that, as I showed in that chart, every year have jumped up by a big chunk. So we also have benefited during that period by drawing in a whole lot of really smart people to the field who've got great ideas. The science improves, the rigor improves, we get more and more applications. The applications also cost more over time, so we've got that marginal increase really shrinking. Lots more applications, each one more expensive, and that's kind of where we are. And that's probably an unsatisfying answer. I also would say for your junior folks, they are top of mind for us. So early stage investigators, new investigators, people, postdoc, faculty transition, first RO1, we are really looking out to see what we can do to support those folks and help to continue to keep them excited about the field and bring them in. And I have them call me. I'll give them a pep talk.
Sorry. I thought I could sit down, but please. No, I think, yes, I think that's helpful to understand that the budgets are definitely bigger. I think the wording of the last blog, where it basically said, this is going to be life as we know it from now on, I think that was a bit, it was reality. But I think maybe explaining it in the way that you did might help a bit with reassuring them.
Yeah, thank you for that. And we really do want to keep the messages out that we're interested in their science. We want them in the field. So we will keep kind of driving home those points the best we can.
I'm Cindy Carlson, Wisconsin ADRC. This is for Brian and Cerise. As you know, we're in the middle of doing UDS 4, which is a labor of love, Cerise, not a labor of labor. But one thing I was wondering, Brian, For the appropriations questions that we all pulled, all of our centers pulled, are there certain questions that you think going forward that Congress is going to want us to respond to? Because we're doing this big overhaul right now, if we can integrate those into our systems so it's easier for centers to pull that data, that'd be helpful to do it now, unless they're going to come forward with different questions from time to time. You know? Like, will they want us to know, will they want us to annually report, like, how many people were given a new diagnosis outside the clinic, or things like that, where we should just start capturing that data prospectively instead of having to figure out?
Yeah, I wish I had, like, the most satisfying answer, and I could say, like, this is what we're going to get every year. Congress can vary in what it decides to request from year to year. I would say that past requests are generally a good idea of future requests, so tracking that sort of information we've already requested is always a good idea, but I can't say for sure that's what they're going to ask for going forward. We hope that there are, and we always try to make sure there's no surprises, but
There always are surprises.
yeah.
Right? Okay, got it.
And I think that the work that you guys have done to revamp the forms, I feel like it allows the nuances in the, what we've learned in the prior requests to kind of prepare. I think we've kind of peppered that into our discussions. So I think we're prepared as much as we can prepare. And I think that trying to automate what we report in the progress reports and working with the ORCOR to try to get some universal kind of metrics about recruitment and engagement, I think will be like 60% of the possibilities. And I think that would put us at a place where we have better data. Because again, we're gonna measure progress. And you guys are gonna help, so you have any suggestions, you can email me.
Okay.
Okay, thank you.
Thank you. Another round of applause for all the speakers, please. Thank you. Maybe you could talk later. Is that okay? Thank you. All right, next presentation on NAC by Dr. Sarah Biber. Sarah?
Okay, hello, welcome. It's wonderful to be here with all of you. I'm thrilled that so many of you could join us here in person in Austin, and even more of you joining us online. And I'm excited to share what is new at NAC. And for any of you that heard my name being called on the intercom at the airport yesterday, don't worry. I was, in fact, reunited with my laptop, thankfully. So anniversaries are clearly the theme here today. And as you already heard from Dr. Elliott and others, NAC is coming up on its 25th anniversary. And over this period, NAC has collaborated with the ADRC program to compile one of the largest and most comprehensive longitudinal, standardized, and neuropathological ADRD data sets in the world. We have rich, multi-domain neurocognitive data on more than 50,000 participants with up to 19 years of data on some individuals. The NAC data set also includes a large quantity of neuropathology data with over 60% of participants registered as brain donors. Together, this data has contributed to breakthrough discoveries in the field and has been used to generate over 1,300 publications. Don't forget to cite the grants. I'm happy to announce an upcoming special issue of the Journal of Alzheimer's and Dementia in celebration with the 40th anniversary of the ADRC program and the 25th anniversary of NAC. The goal for this special issue is to highlight the impact that these programs have had on advancing Alzheimer's disease and related dementia discovery and translation, and their ongoing critical role in enabling the scientific community to tackle the most pressing challenges in the field, especially in the era of emerging disease-modifying therapies. The open call will be published on June 15th, and a preview is available now on the NAC website, and papers are due at the end of this year. As we think back on and celebrate the past 25 years, I want to zoom in and take a closer look at the past 2.5 years and how NAC has been rapidly evolving and leveraging its unique strengths to meet the emergent needs of the ADRD field and the ADRC program. Let me share a few highlights. To enable the research community to tackle the most pressing challenges in the ADRD, NAC has expanded its data, coordination, and collaboration and communication functions. We are setting new data standards for the field, providing next-generation informatics infrastructure, improving interoperability, and facilitating and providing effective frameworks for impactful communication and collaboration across the ADRC program and beyond. In the past 2.5 years, NAC has made progress in collaborating with NIA and the ADRC program to establish new data standards, particularly focusing on UDS v4. UDS is the gold standard for clinical phenotypic data around the world. Over the past couple of years, NAC has been collaborating with the Clinical Task Force and NIA to launch an updated version of UDS that is aligned with important scientific advances in the field and our evolving understanding of best clinical practices. Developing UDS v4 has been a massive undertaking, and I'm thrilled to report that 100% of the UDS content is now complete and will be available for our upcoming trial pilot. And I'm also thrilled to be able to, additionally, 100% of the PDFs and corresponding REDCap forms are also complete. So this work is an enormous amount of work, has been made possible by our strong collaboration with the Clinical Task Force and the Electronic Data Capture Workgroup. Over the past 2.5 years, we've also been working to make it easier for ADRCs to collect, submit, manage, and access their participant data. We have collaborated with the Electronic Data Capture Workgroup to build a new, streamlined, modern, and flexible electronic data capture system and submission interface for UDS v4 and other data modalities. The submission interface is available within the ADRC portals and will be available to test drive later this month as part of the UDS v4 and NAC ID pilots. The ADRC portals, which NAC launched last fall, will enable each ADRC to manage participants, submit data, view, audit, and access participant data, and download real-time ADRC reports. It will also include dashboards like our real-time diversity dashboards, which we'll be collaborating to develop currently. You can see a demo of the latest ADRC portal features at the NAC session tomorrow. Another key focus for NAC has been providing next-generation informatics infrastructure for the ADRD research community. This past year, we launched the new NAC Data Platform, a modern, cloud-based, multimodal data integration, harmonization, and sharing platform. We have moved all NAC data onto the cloud, expanded or established interoperability with 6 other NIA-funded repositories and initiatives, including developing the informatics infrastructure for Clarity, and are building pipelines to integrate new data types, including digital data and biomarkers, digital pathology, and real-world data. All this multimodal data is integrated, harmonized, and connected to NAC IDs within the NAC Data Platform and will be made readily available to researchers everywhere around the world through the NAC Data front door. Our work to date has already enabled a dramatic increase in NAC data utilization. For example, over the past 2.5 years, there's been a 102% increase in the average number of data requests per year and a 23% increase in the number of published studies using NAC data. We're excited to build on this further as we roll out new components of the data front door and make additional data modalities available to the research community. Along those lines, I'm thrilled to announce that as of last week, scanned summary and analysis data is now available via the NAC Data front door. You can visit the NAC Scan website and join the NAC session tomorrow to learn more about this. We're excited to collaborate with our partners to make more multimodal data, valuable multimodal data streams available to the research community, and know that this will be critical for tackling the most pressing challenges in the field. And we want your input. We invite you to join us for a multimodal data workshop at AAIC this summer. This will be a fantastic opportunity to connect with other researchers that are doing innovative work in ADRD and to help shape the future of critical multimodal data infrastructure for the field. There are only 50 slots left, and we hope that you can join us. I look forward to seeing you all at the NAC session tomorrow at 10 a.m., where we'll take a deeper dive into UDS v4, as Cerise promised. I'm going to show her the Gantt chart again, don't worry. And finally, I want to end with updates on NAC award programs. So this year, we were incredibly lucky and excited to work together with the Alzheimer's Association to expand our new Investigator Award program from 2 to 13 awards and to double the amount of each award. We had a huge response to this call with 156 applications from across 36 ADRCs. So I want to congratulate all of our 2024 awardees who were just announced last week. We're excited about the contributions that you will make to the field, so let's all give them a round of applause. This is fantastic. Yeah. I also want to mention that NAC partnered with the REC to launch a companion mentorship program this year. It was really important to us that we provide value to all new Investigator Award applicants, regardless of whether they receive funding. I'm happy to share that 77% of applicants received support from mentors in preparing their applications. 80.2% of applicants strongly agreed that this mentorship strengthened their applications, and 92.2% of applicants are confident that they will apply this guidance to future grant applications. Thankfully, 95% of our mentors want to come back and do it again, so we think this is a great start to this new feature of the expanded program. And of course, we really want to thank the Alzheimer's Association for funding 12 of these 13 awards and partnering with us to rapidly expand this program this year. It was a lot of work in a short timeline, and I'm so proud of how successfully we were able to do this together. We look forward to partnering with them again next year on this program. And we were incredibly impressed by all of the strong applications that we received, and we really hope that if you didn't receive funding, you'll consider applying again next year. We're also very appreciative of the REC for partnering with us and launched a new mentor program. I also want to thank all of the mentors and reviewers who contributed their time and expertise. It is really wonderful to be a part of a community that is so invested in supporting early career investigators. And lastly, we're excited to advance digital data collection. We have launched a new program with Gates Ventures. This new digital pilot program is in its first cycle, and we received some incredible applications. We invite you to join us to hear from our finalists at an upcoming pitch competition on May 31. Finalists will pitch their proposals in front of a live audience that hopefully includes all of you. To compete for $250,000 to $1 million in direct funding. So this is an excellent opportunity to learn about emerging digital solutions and how digital data collection can help transform Alzheimer's disease research and discovery. And these are the folks who you will hear from at that pitch competition. These are the finalists, so we can give them a round of applause as well. Good job making it to the final round. So I've highlighted some exciting and impactful developments at NAC from the past 2.5 years, and I want to end by highlighting that none of this would have been possible without our collaboration with all of you, NIA, the ADRC program, the Clinical Task Force, the Electronic Data Capture Work Group, and our incredible partners, and of course, the amazing team at NAC. And as we celebrate the 25th anniversary of NAC, I want to give us, of course, a special shout out to Bud Kukul, our director, who got this whole operation started and has kept it going in this amazing way for so long. So a huge round of applause to Bud for keeping this going. So thank you for your attention. It's wonderful to be here with all of you. I look forward to have the opportunity to connect, hopefully, with many of you over the course of the next couple of days. Thank you.
Thank you so much for having me. I'll give you some updates about what's going on with AD genetics data. The first is, here's some numbers. We now have more than 110 data sets covering more than 130,000 samples with all kinds of data, GWAS, SNP array, sequencing data, and so on. And they're used by researchers around the world and come from different kind of study cohorts with different research limitations. And now we have about 5,000 verified users of our website, something thanks to the outreach activities, which we're going to talk about later. And of course, the flagship program for AD genetics is the Alzheimer's disease sequencing projects. Now we're working with more than 70 cohorts and supporting more than 20 different grant sub-awards to do data processing as well as sharing and hosting. ADSP currently has 20,000 exomes and 36,000 genomes, and we're working on the next round, which I'm going to talk about a little bit more. Now, from last year, we've seen a lot of growth in NIGATs. We have more than 70% of the additional 70% of data sets. Now with 24% growth in terms of number of articles that actually cite our grants in their paper, but there are other papers that use our data as well. And we have close to 30% additional users on our website. So we're really working to broaden our outreach. For the whole genome data release, we continue to release additional information generated by the investigators, by researchers in ADSP that add more value to the whole genome data. In December last year, we released additional variant annotations with rich genomic annotations on the variants, their impacts, and other features together with the phenotypes from the Phenotype Harmonization Consortium. And currently, we're working on additional data on the 36,000 genomes released for it, including structural variant joint calling, as well as additional information on the quality control on the chromosome X and multi-allelic variants. But the major thing where the NIGAT team is focusing on is the next release that will bring the number of genomes to about 62,000 genomes, continue to maintain the diversity of the samples we get, and we're going to talk about it a little bit more. But before this, this is the summary I got from the Phenotype Harmonization Consortium, and I want to thank Tim Holman from Vanderbilt University for this slides. And PHC has been a really exciting addition to the whole ADSP framework and brings additional value to the data. And Tim, as well as Mike Kukro from Miami and Ada Toga from USC, I want to thank them for their leadership. As you can see, it covers a wide range of different data. It has the cognition data, fluid biomarkers, pathology, value risk factors, and their derived data from different kinds of image data. If you have approved data access requests from for ADSP, you can download these data now. And here it also shows the complexity of the data. ADSP comes from dozens of different cohorts. They all have different protocols as well as criteria on how they collect the data. And so not all data types are available for all studies, but one thing I'll say, of course, NAC is the ADRCs have the most comprehensive data. It's really important and valuable for the ADSP data. We're working on the Release 5 whole genome data release, and that will bring the total number of genomes from 36,000 to almost 62,000 genomes, and we're hoping to get it out around summer. And two things. One is we continue to, the ADSP continue to emphasize the importance of increasing the diversity of our samples. And the second is ADRC samples are a major contributor to the entire data resource. Now about 20% of the ADRC samples are selected for sequencing ADSP. So if you have any questions about how to get the data for your samples that can link to a patient's, send us an email. We're also making the SNP array data available. These are genotyped by ADGC, and the first 15 rounds of genotypes are available to the research community. It's more than we return the raw genotype data to the centers, but also there's additional quality control, population structure estimates, as well as imputation and link of the samples to the ADSP data. So now the whole data collection has almost 30,000 genotypes. So it's a very valuable resource for the entire community. And you can link that to the NAC UDS data as well as the ADSP sequence data. And we have just released 2 additional rounds, ADC 16 and 17, and the raw data available that we can return to the centers. And ADGC will do the additional quality control, so they can also be released to the research community. NIGADS is also developing new initiatives to support data fair principles, and I'm going to talk about some of these. They cover different categories of the fair principles. For example, we're really excited that we're going to release this ADSP data discovery platform. We're doing beta testing with some investigators inside ADSP to make sure that the user experience is good. It's powered by the Gen 3 platform developed by University of Chicago, and it's used by many other similar platforms. For example, the cancer Cancer Atlas from NCI that uses this software as well. With that, you can explore what samples are available in ADSP by their diagnosis, metadata, and so on. So I think it's going to be a very valuable feature. The second thing we developed is this data submission portal that will validate the data. I think it's very useful for the cohorts that deposit data into NIGATs, so we can validate to make sure all the metadata, all the documentations are in place. That will save the time it takes. But our investigator will also work the cohorts, continue to work with the cohort investigators to address any possible issues, so the data come in with all the required information. And the last one I think is really exciting. Now all the data sets in NIGAS have a digital object identifier. If you go to our data sharing service portal, DSS portal, it's a URL, a short URL that actually serves as a persistent reference to individual data sets. And what that really helps is you have something that you can go to the data sets and you can refer it, and it's going to be permanent, it's going to stay there. It allows us to implement different things down the road, like interoperability with other resources. It has a consistent form that you can cite the data in your paper and so on. So here we got a lot of help from NIA. Certainly, I want to thank Jenny Larkin for the really good advice for us to explore this. We'll also work with Sarah Stutwell. I think that's she's from Department of Energy. So this is really a collaboration across different federal agencies. And I think these are really useful features for data scientists to use our resource. We have different kinds of genomic annotation resources that talks about what we know in the literature about AD genetics. And these are what we call NIGAS open access resources, starting with public GWAS summary statistics. In this case, we focus on p-values, so it's definitely not identifiable. And you can directly download that from the DSS open access portal. Filer is our standardized searchable repository for functional genomics findings. So you can find out are there particular regions that are like, say, ChIP-seq experiment peaks, or they correspond to chromatin conformation interactions, or and so on. It's a really rich data set that it has harmonized data together with metadata that tells you about the experiment protocols and sample types. The ADVP, AD variant portal, actually is a curated AD GWAS catalog. So we continue to add paper. I think it now has about 400 papers with AD GWAS, and pulled by human experts. It has more than 18,000 genome-wide significant association information with associated metadata for AD and related phenotypes. The last one is the genomics database. It's our AD genetics database that's similar to, say, UCSC Genome Browser with Genome Browser visualization, but it's focused on Alzheimer's and contains more than 260 million variants, annotations, and many of them are variants observing ADSP data. So all these data now will be available. You can actually have programmatic access with our application programming interface API. What that means is your programmers, your analysts can incorporate queries into their analysis codes, so they can query our server directly. You don't need to download the files directly. So I think it's going to be very useful for especially people who analyze the data, developing machine learning and AI methods. So we're really excited about this feature. If you have people in your center that would like to explore these features, let them know and let us know. We'd like to work with people from your center and get some feedback. Last, we have various activities to support data use. NIGAS now has office hours, video tutorials. We have a new support portal that has all the documentation and frequently asked questions. We have a ticket system that records the user query so we can get back to you timely. And we're going to have a booth in AAIC, and we have poster presentations. And the other thing is we're really glad to be part of this workshop that Sarah just mentioned about data access at AAIC. And last is here's the booth number at AAIC, and we took the picture that's from our booth from Amsterdam last year, so you know what our booth will look like and where to find us. And I look forward to seeing everybody in July in Philadelphia. Thank you.
Thank you, Dr. Wong. Looks like Dr. Farood is ready for our presentation, so we would like to invite Dr. Tatiana Farood to talk about NICRAD. Thank you.
Thank you so much. And I'm only able to do this because Kelly is my arms. So we truly are a duo that needs to be together. So my thanks for letting us move forward. Kelly, let's go to the next slide. So the first thing we want to tell you is that we've redone our website, and it has the exact same URL, but we've got a QR code here on the right. Really want to encourage you to come visit to see if there's information. We'd love to get feedback as well. And it's still in a process where we're updating it. Let's go to the next slide. So the first thing that I also want to just cover is GWAS. This is a longstanding collaboration that we have with all of you. And we've GWAS'd about almost 34,000 individuals. And many of you are aware that we do this in two ways. The first is in collaboration with the Alzheimer's Disease Genetics Consortium. Almost 27,000 individuals have been done in that way. But those are individuals who have a diagnosis of AD, MCI, or healthy controls. That leaves us with about 7,300 individuals that wouldn't have been done by the ADGC. And so we do that through NICRAD. And if we go to the next slide, one of the things that we've seen, and we'd like to improve, and this came because of the calls that we've had with centers, about 20 of you this spring, is that our path had been to send shipments about once or twice a year to CHOP. And those were the shipments that were both for the ADGC and us at NICRAD to send the samples for GWAS. Doing this once or twice a year is not enough. It means there's too much of a delay in getting data back to the centers. So I've talked with NAC, and what we'd like to do with NIAGADS now is to send data quarterly. So that means we're going to have a much more regular flow of GWAS that's going to be coming back to the centers. We'll now work with NAC to make it seamless for all of you to be able to get that back. We realize that's something that centers need and that it hasn't been coming back fast enough. So glad to take questions on that later, but we really hope that that will help the centers. If we go to the next slide, I'm going to spend the next part of this talking about the biomarker assay lab. So part of our redesign is we've redesigned the part that talks about our biomarker assay lab. And what you can do there easily is find if you want to get a quote from us, if you want to know what assays we're doing, and how to collect samples. We spent a lot of time this morning in the biomarker working group talking about the importance of collecting samples in a uniform way. All the information about how to do that is listed right there on the website. And there's a QR code if you want to go right to that part of our website. If we go to the next slide, what I really want to focus on is making sure that centers get credit for all the work that you have done. So what this shows, and I'll show you this a couple different ways, this is a count of the unique participants from whom we've obtained samples as part of what's called the ADC fluid-based initiative. And so what you can see is that we've received plasma for over 8,500 unique individuals. We've also received PBMCs and a variety of other sample types. If we go to the next slide, I want to give you a feel for what data you're getting back. And I also want to be able to thank NAC. That's why it was really important that I could do this for you. For those of you who are not completely glued to the meetings and are checking email, you should be seeing that there's biomarker data coming back to you for those of you participating in the ADCFB. I want to give NAC really great credit. We sent them the data late last week, and you are already receiving it today on Monday. And what I'm showing you here are the various assays that you're getting and the platform on which you're getting it as well. And we don't change this without the approval of the biomarker working group for the ADRCs. If we go to the next slide, I want to give you a feel for sort of our timeline and our cadence of returns. We started to return biomarker assay data in 2022. That grew in 2023. And you'll see there's going to be a lot more coming in 2024. There was a bit of an issue in late 2023 around the availability of kits. So that forced us to push a little bit more assay data to come back in 2024. But just realize that this is coming now at a very, very steady stream for you. If we go to the next slide, want to make sure you know how data comes back to you. I've alluded to the fact that NAC is right now returning data to you and to the now a variety of the cores in your center. The data just for your center comes back to you through NAC. After a 90-day embargo period, we then put that data into our catalogs that we have online. This then becomes a way that researchers can get biomarker data across centers. And again, I'm going to show you on the next slide how you're going to be able to request that. But I also want to stress this is not our long-term plan. Our long-term plan is that if you wanted to get biomarker data across centers, you would get that from NAC, and we're working with NAC still to get that completed. So if you go to the next slide, what you can see is what you'll be able to see if you come in and request and complete a data access to our ADRC catalog. I want to make it clear, though, that depending on whether or not you are a for-profit or a not-for-profit, we are respectful of what your GDS has been signed by the individuals from your centers. So we have one view that's visible for individuals, researchers that are both for-profit and not-for-profit. And then we have a different catalog view that's only available for those individuals that are not-for-profit, which will include additional individuals and data. And you can see the biomarker data across the top there. Would love to work with you if any questions about how to get access, how to complete that data agreement. If we go to the next slide, this really gives you a feel of the collaboration that we've built. You can see starting in 2019, you can see the growth. The blue line is what we've already received. The green is what we're predicting to receive for the rest of this year. We received in 2023 samples from almost 4,500 participant visits, and we're anticipating over 5,000 participant visits in 2024. And that will put us at about 14,000 participant visits with plasma with us at NCRAD, and for which you are receiving back fluid biomarker data. Let's go to the next slide. And this, I really just wanted to stress how important it is what you're generating, not only for yourselves, but also for the broader community. So some people wonder, why do we ask for more volume of plasma than what we need to run the biomarkers? And that's because of the extensive characterization of individuals, because of the UDS, there are significant and growing numbers of requests for plasma from researchers. This is really ideal plasma from well-characterized individuals, and we distributed almost 5,400 aliquots last year plasma, and we anticipate that that's going to continue to grow in 2025. Want to make sure you understand that you get credit for that as part of the annual report that you see. So you see who has received plasma from your centers, so you can take full credit for that. And let me go to the next slide, which is my second to last slide, which is we had one of these surveys that you've been hearing about, which was a survey sent out by NAC where we asked you about non-ADCFB plasmas that you might have at your centers. We did that because we had some centers asking us about running samples, and we wanted to make sure that we understood the full platform and full landscape of plasma samples that might be sitting in the centers that weren't part of the ADCFB, but that centers might want to have fluid biomarkers on there. You completed the survey, and we had tremendous interest from the centers. In fact, your interest exceeded the amount of capacity that we had. So we sought guidance from NIA. And what we're going to propose going forward is for those centers and for those participants that have the broadest sample sharing, again, these are samples beyond those that you're sending as part of the ADCFB, that we'll be able to run from one participant visit, and we'll talk with you about which one that should be. We would be able to provide you with plasma biomarkers from that particular visit. I want to stress and make sure no one's confused. If you're sending samples as part of the ADCFB, if you've sent us multiple visits from that same individual, you will get biomarker data from each of the visits that you send us. So when we're talking about this more limited scope, this is only for samples outside of the ADCFB. And with that, I want to go to the last slide. I want to thank Kelly for helping me here. I also want to make sure that you know Kristen and Casey are both in the audience if you have questions. We've got our QR code there, and we really want to make sure that we answer any questions that you might have about any samples you're sending us and about availability of data. And really appreciate you letting me be able to do this today from home. Thank you so much.
Okay, I think we have about 5 minutes for the Q&A. Tatiana, if you stay on, that's great. Yeah, thank you. All right. You want to go on the stage or? Yeah, come on.
Yes, we will invite Dr. Biber and Dr. Wong to the stage.
Anyone?
Thank you very much for the good introduction. My name is Pinar Kaskum from UK University of Kentucky ADRC. So my question is, in that database, do you also have the mitochondrial DNA sequence stored?
Yeah, so for the, depends on the platform. So some SNP arrays, they might not have very comprehensive mitochondrial markers, but for sequencing data, we have the causal mitochondrial chromosome and we have all the raw data. So if you want to apply your pipeline to call mitochondria, you can do that.
So is it next generation sequencing?
Oh,
Yeah, so how many coverage that you have? Or it's based on the platforms that you have?
Well, for whole exome, usually it's 20x. That's an older technology. Don't do that anymore. For whole genomes, usually at least 30x. When we look at the actual data, some of them are 40x or higher. So very dense, very, very, very deep coverage.
Thank you.
Go ahead, Mary.
It is so wonderful to see so much data coming together and being so available. It's really gotten very easy to use all of the different data streams. I did want to make a comment that I think this is a really important exercise for research, but if our job, or if part of our job, is to create translation, the additional things that we're requiring of people is creating burden on our participants, and we've heard that. The assessments are getting longer, the time in the scanner is longer, et cetera. And I think that's perfectly fine at the research level, but it might be important for us to start to ask the question, what are the most critical elements so we can pick them out and share them clinically when we say, how do you make a good diagnosis, or how do you track a person's health? And I'm just concerned that our translation to care may disappear as we broaden and extend and increase the number of markers and the number of burden, the amount of burden. I think it's important for now, but I do think it wouldn't hurt right now to add very specific questions about how would we select exactly which ones and how long do they take, and et cetera. So I'd love to hear if you think we're anywhere near being at that point.
Yeah, I mean, I think thanks for bringing up that point. You know, one of the things that we are trying to do in particular, we know that UDSV4 is longer, and we look forward to having, all of you pilot that during the upcoming pilot next month. And we are trying to do things like leverage technology to help streamline that, right? So we have created a new electronic data capture interface to help facilitate that. And then as far as, the actual, data elements that are collected, of course, we've just developed UDSV4. So it may be, those may be things we want to think about for UDSV5 in terms of what, are the most critical ones that need to stay in there. One of the things that we are working to add on to UDSV4 is leveraging the new NIAA criteria to put together a form that will allow us to capture ATN and other really critical pieces that we know are important for diagnosis. And so I don't know if this answers your question. I think it's an important point that you're bringing up. And I think it'll be something that'll be really important to think about and learn from other ADRCs about in terms of what strategies are working well at different centers.
Maybe I could ask Dr. Wang one question. I'm sure that you have some data on Native American participants. Given the data sovereignty issues related to sharing those data, you've thought about, do you have any policies in terms of sharing those data?
Well, it's something that I think you and I should answer together. First is, I'm not sure if we have Native American data. If there is, it's small. And the other thing, actually, I learned a lot from it has been workshops that NAC meetings organized, Sarah organizes. I learned a lot about the challenges of return data for Native Americans, and we would like to work with the tribes, work with the centers who are experts in these populations to set up a proper data sharing process.
Yeah, I'll just add to that we recently, last year, launched an Indigenous ADRD advisory group. It's actually led by Dr. Yowei Loon McCluster Davis at UW, the other UW. And we are excited to work with them. They are thinking about these things and helping provide some guidance on these things. That was the topic that you mentioned, including developing some best practices that ADRCs can use to better engage Indigenous populations locally near their centers.
Okay, one last question. Dr. Lahiri?
Dave Lahiri from Indiana ADRC. And excellent talk, Dr. Wang. And I have a question. We are working on microRNAs, and we have characterized several microRNAs for Alzheimer's. So do you have microRNA gene sequences, and which you did, and did you find SNPs, and is there any database for that?
Yeah, for whole genomes, you will have the DNA sequence for the microRNA loci, so you can compare that. So all these data should be available. These are whole genome sequences.
And we were working on NATs also, natural antisense transcripts, and they're also in several genes. So I was wondering whether you have, like, you are saying 30x, 40x sequencing. If we find sequences for NATs, that will be very important and very exciting.
I think that's a really good question. And one other thing that ADSP does is to generate different kind of functional omics data. And I think some of the raw data is going to be eventually available on the knowledge portal, but also the functional genomes. We're working on, NIGA's working with the Functional Genomics Consortium. For example, we have this XQTL data set project that I didn't have time to talk about today, but I'll definitely give an update at the next ADRC meeting. So there's going to be data that will be very valuable for this. On my personal experience, I find these antisense link RNA to be incredibly exciting because we saw that in some of the bioinformatics analysis we developed. And yes, you can find the variants that are from the whole genome data, and we have databases that can provide these kind of annotations so you can cross-compare. Maybe we can talk offline about this.
Thank you so much. Thank you.
Okay, thank you so much. Another round of applause for our speakers. Thank you.